Mark, it's so great to have you back in the studio again. Thank you so much. It is amazing to listen to your expertise, and so important. You come from such a highly professional background of being an MD, doing psychiatry as well as psychopharmacology, and a PhD in psychopharmacology. And that for me is so important to outline for my listeners. They've heard your bio. I'm saying it again. I'm going to ask you to explain it again, because what you're about to share with us about your own experience, as well as your clinical and your research experience on the dangers of psychiatric withdrawal not being done properly, and just having informed understanding of what a psychiatric drug does to us is so vitally important. So thank you so much for sharing your expertise today.
Thank you for having me on the show, Carolyn. So I guess I'll outline my training and how I came to this topic and what I've learned about it over the last few years. So I'm originally from Australia, it's the accent, but now I'm working in London. I trained as a doctor there. I started psychiatry training. I went to London to do a master's in neuroscience and then a PhD in psychiatry and neuroscience. And my PhD was focused on the neurobiology of depression and the way that antidepressants affect the brain. And after that, I went back to Australia to do a bit more of my psychiatry training. And now I'm working in London as a clinical research fellow in the National Health Service in psychiatry. And I'm also an honorary clinical research fellow at University College London, one of the universities in the city here. I've paused my psychiatry training while I've done this research because I'm really trying to work out how safe and effective these drugs are, how it is, what's the best way to stop them before I go back into practice. And now my interests in psychiatry have changed drastically based on my own experience. So probably like a lot of people, I went into psychiatry to fix myself and fix my family. Probably classic older son stuff. I, in fact, had started using antidepressant when I was 21. I was in third-year medical school then. I would describe myself as a neurotic Woody Allen type of character. I didn't enjoy the kind of regimented nature of medical school, and so I was a miserable camper at the age of 21. And I went to see a doctor, a GP, who prescribed me an antidepressant after a few minutes of conversation. And I took that antidepressant for really the next 20 years. And I'm still in the process of coming off it now in my, what I'd like to call my very late 30s, but what is in fact my 40s. The way that I really became aware of the issue of withdrawal is about 7 years ago, 8 years ago more like, in London, I was writing up my PhD. Now, I did my PhD on how do antidepressants work and what is the biology of depression. For obvious reasons, I was interested in trying to understand more about myself and my patients and friends and family. When I was writing up my PhD, I came across a paper talking about withdrawal symptoms from antidepressants. And that was quite a shocking moment for me, because I'd never heard about that before in my medical training or in my psychiatry training or in my PhD. And it was startling to me because I'd always associated withdrawal symptoms with drugs like Valium and other benzodiazepines or OxyContin and other opioids. And to me, withdrawal effects meant that you became used to the drug. Tolerance is the sort of flip side of withdrawal. You become used to the drug, and that's why when you take the drug away, you experience withdrawal effects. And in general, drugs that were not very healthy to take in the long term, like benzodiazepines or opioids. And that made me think about stopping the medication, the antidepressant. And being a kind of dutiful and nerdy doctor, I went to read all of the academic literature about stopping antidepressants. And at that point, I was doing my PhD at the Institute of Psychiatry in London, which while I was there, passed Harvard to be the most cited institution researching psychiatry in the world. So I was working with the best of the best. And a lot of the papers I read were written by my professors or their colleagues. And what those papers said was that you can stop antidepressants over about 4 weeks. There are discontinuation symptoms that are generally brief and mild. And they often said it went for a week or two. And I thought, well, that doesn't sound too bad. But being a millennial, even a geriatric millennial, I was used to searching things on Google. So I thought that I would also check out what do the people say? And I found a very different story there. They said that many people, it was actually thousands of people. I was kind of shocked by how many people were on these peer support websites like Surviving Antidepressants and other groups. I was sort of shocked at how many people were coming off these medications, antidepressants, and how much trouble they were having. And they were saying that they were getting terrible withdrawal symptoms, that it was taking them months or years to come off. I sort of clocked that, and I thought, well, I'm not going to end up like those people. Maybe they're a bit neurotic. Maybe these are other problems. I'll sort of hedge my bets, and I'll split the difference. I'll go somewhere between what my professors are saying, 4 weeks, and the months and years that these people are saying online. And I ended up coming off my antidepressant, which at that point was escitalopram or Lexapro, I think very commonly used in the US, Australia. I essentially halved my dose every month. I went down over 4 months, and I entered a realm of experience that I wouldn't wish on my worst enemy. I had great trouble sleeping. I started having panic attacks. I would wake up in the morning feeling like I was being chased by a wild animal, sweating, heart racing. And although I'm not the most athletic fellow around, I took up running 10 kilometers a day, even to the point that my toes started bleeding, just to get a little bit of reprieve from the panic that was essentially with me all day.
Wow.
And running for an hour, I would get a little reprieve from the panic that would then return to settle a bit in the evening. In other words, I was sort of in a state of panic for weeks and weeks and weeks. And at different points in that process, I started thinking, I'm not sure if this sort of life is actually worth continuing, because it was just so terrifying. It wasn't at all anything like I'd been in at the age of 21. At 21, I'd been miserable, I'd been pessimistic, I'd been tired, I didn't enjoy university, but I'd never had trouble sleeping, these sort of panic attacks. So it wasn't even for a second a thought in my mind, is this a return of my condition? It was very clear to me these were new symptoms, very unfamiliar. I also had physical symptoms. I had dizziness. I had a sense of sort of very hard to put into words disorientation, a feeling that things were not quite real. That I've since learnt is called derealization, sort of fogginess. I had trouble concentrating. And so I sort of understood that these were withdrawal symptoms. These were not symptoms coming back from my condition, but something new caused by stopping the drug. It was still very disorientating. And I ended up actually moving back from London to my family's house in Sydney in my early 30s, because it was just so knocked me off my perch. And I ended up going back on the medication, I think even to a higher dose, which after a few weeks did settle things down. And so after that, I was essentially too frightened to come off the medication again soon after that because of that experience. Again, I guess years later, I tried to come off again. So I'm now in the process of coming off. It's been now quite a while. Essentially, I decided on this second attempt to come off that I would pay much more attention to what people online were saying, because I had figured out that even coming off over 4 months was much too quick for me. It seemed to be much too quick for these tens of thousands of other people I found online. And I thought, well, I better take, since what I've learned from my professors is not at all helpful, that 4 weeks is a ridiculously short period of time. Also concluded it wasn't just me. It wasn't just me having an idiosyncratic reaction to these drugs. It was clearly a widespread phenomenon. And so I went back to these websites. I thought, this is pretty unusual that I've got a PhD in psychopharmacology. I've studied at the top institute in the world. I'm medically trained. I'm in psychiatry training. And yet I'm getting the best advice from people on online websites, from retired engineers, from housewives, from a variety of different people. These people are able to give me better advice than the professors at the top of my field. I thought that was a very strange circumstance.
That is something, every time I hear you say that, and I hear so many people say this in similar kinds of backgrounds to what you are, it's horrific that doctors are, and I'm not surprised, I've trained physicians myself, and this is kind of almost sometimes not an argument, but it's like how can you say that kind of situation? What is it? And I said, you just have to go look at the research. Have you looked at the research? And then you also say about the survivor sites. I actually was doing some research. Apparently there's over 1 million survivor sites of people that says something. There's over 1 million people on survivor sites, and I'm sure it's increased since then. That's telling us something. So I just wanted to emphasize what you're saying there, that people, they need to hear what you're actually saying. It's the doctors are not telling them, it's the survivors.
Yes. I don't think it's because the doctors, are trying to withhold information or
not at all.
In any way malicious.
Not at all.
And I guess I know that because I've been on their side of the desk. I think the issue is they're just very poorly informed.
Exactly.
I would say before I went through this experience, I had been taught what all my colleagues have been taught. I would have accepted what I had read, that these discontinuation symptoms were mild and brief. You could come off in 4 weeks, and I would have given the same advice to my patients because I'm in medicine. We're very dependent on learning from experts. You can't do all this research by yourself. And so I was being told that by experts. I would have told that to patients. I have, of course, like all my colleagues, I've got a desire to help my patients. I would have just been ignorant. And I realize in the past I have been ignorant. I have given bad advice to patients about stopping their drugs. And I would never have come across this alternative source of knowledge and wisdom and practical advice had I not been forced to through my own experience. So although I'm very frustrated by my colleagues' often reluctance to listen to new information, I understand it because they're very used to receiving information in a very hierarchical manner.
Yeah.
From lecturers, from readers, from professors, and not from patients. I guess it's very awkward. It's unusual for them to be listening to patients. I think there are some cracks in that, and there are people who are learning from that. But I guess it's very unusual for a lot of physicians. It would have been unusual for me, but I was forced to do it, and I'm very glad for that.
I'm so pleased you did, Mark, and that you're sharing your wisdom, because a lot of people are hearing what you're saying. And I coach you all the time in the training that I do. You and Joanna and Sam Tamimi and Robert Whitaker. There's such an excellent source of research to guide people. And I find my experience with physicians, when you sort of point this out to them, they're actually really grateful to say, there's another alternative point of view. So people are listening, starting to listen and see what you're saying, which is so important.
Yes. So one thing I think is every psychiatrist and GP, I think, is beginning to appreciate, if they haven't already, that there is really very little guidance on how to stop these drugs safely.
Yeah.
There's a huge amount of research on how to start the drugs, when to start the drugs, when to add the drugs. That's because of the commercial realities that most research is done by drug companies. It's in drug companies' interest to have studies on starting drugs. It's not really in their interest to have studies on stopping drugs. And I think people are becoming more aware that we've really been focusing on half of the practice of psychopharmacology, which is starting the drugs. And so I think people are aware there's very little guidance on how to stop the drugs. And that makes them a little bit more open-minded, I hope, to learning more about this. And when there is not research about, the next best thing is to learn from people's experience. So
Absolutely.
There is some research happening, and then learning from people's experience is the next best. So I was back on these websites to try to work out how to come off the drugs myself. I decided this time to take them at their word and to come off slowly over months and years. And I wrote, and while I was doing it, number one, it had a very big effect on me personally. So as I was coming off these drugs, I experienced a reduction in symptoms that I'd had for many years, which had caused me great trouble in my life, which were impaired concentration, impaired memory, and daytime tiredness, which I had along the way, diagnosed as chronic fatigue syndrome and then narcolepsy. And as I started coming off the medications I was on at that point of time, all those symptoms started improving, which is really, joyful for me. It made me feel like I might be able to get my mind back, because at that point I was very worried about my inability to think straight. I've been told it was all sorts of other illnesses, but I'm now much more convinced that it was adverse effects from the drugs that I was on. So that was very joyful for me.
Yeah.
Tinged with a huge amount of regret that I'd been on these medications for so many years that it caused me so many problems. And the second thing I did in the academic realm was to write a paper about what I'd learned on these websites, which I ended up publishing in Atlanta Psychiatry, that outlined how to come off these drugs that I can talk about a bit more later on.
Yes, please. And we'll put the link to that paper in this. And I know, is that the one that's on that you got from the guidelines in the Royal College of Psychiatry? Is that where that comes from? And if you could talk about that as well.
Yes, exactly. So the guidelines that are now in England from the Royal College of Psychiatrists, and actually also the NICE guidelines, are based in part on the paper that I wrote then. So
fantastic.
Yes.
Congratulations. I mean, that's quite an impact.
Yes. I think I had some, some allies there within the Royal College, which made it happen. So I guess I should talk to that. So since that period of time, which is now 4 years ago, all of my research has been focused on how to safely stop psychiatric drugs.
Okay.
And maybe I'll talk in broad what I've learned, what it might mean for patients, and how it's led to guideline change in England, but basically almost nowhere else. Which is in itself interesting.
It is very interesting, and this is why I'm very glad we're going to transition over to, or pivot over to talking about that. So people that are listening, because this podcast reaches globally, but we have a huge American audience, and people are constantly asking me, where do I even start? How do I do this? Where are the guidelines? And this is why now they've got this podcast. They can reach out and see. They can go to see the guidelines on the Royal College of Psychiatrists. And they'll have the paper, and they'll have, so there's going to be a resource now to help people. Yes.
Okay. Exactly. And that's what we know, I get endless emails from people who are asking for just what you've just outlined. They decided that the drugs are causing them more harm than good. They've been on them for longer than they think they needed to be. Either their lives are sorted out, or they prefer to try to find other ways of managing their emotions and thoughts, and they want to know, how do I get off these drugs? And they're often told by their doctors, well, you can just come off in 4 weeks and there's no major issues. And exactly as I was told, and I guess, so I'd like to outline what we know. So normally I do this with slides, so I hope I can paint a picture with words that'll be conveyed to people. So maybe I'll just talk about, why does withdrawal effects happen? What are they? And what we know about how to avoid them.
Mark, sorry to interrupt you. Are we going to talk specifically initially about antidepressants, or are you going to touch on the other psychotropics, or the other psychiatric drugs, I should say?
So I can talk about probably, so they all have very similar themes to them. I'll talk mostly about antidepressants because they're the most widely used drugs. They're the ones I get questions about the most.
Okay.
But I'll relate it to antipsychotics and other drugs along the way so that people can hear the whole thing. Essentially, so what sets up trouble stopping is that all psychiatric drugs cause changes in the brain. So our brain is a homeostatic system. So homeostasis means we like to keep things in balance. So when it's too hot outside, our body will try to cool us down. When it's too cold outside, our body will try to heat us up. That's one of the central mechanisms for the body. If we take a medication that increases a certain hormone in the brain or neurotransmitter like serotonin, our brain will respond by diminishing serotonin receptors. In other words, diminishing the signal. Something like being in a loud concert, your eardrum will become tighter so that the sounds are muted, so you don't get too much noise. The brain does that to all sorts of chemical signals. So for antidepressants, it probably involves a reduction in serotonin receptors because there's high levels of serotonin. Similar things happen for all other psychiatric drugs. So for example, if you're taking an antipsychotic which blocks dopamine, then the brain will do the opposite. It'll increase the sensitivity to dopamine so that signal comes back sort of to normal, and that involves making dopamine receptors more sensitive. And that applies to any drug that's changing the biology of the brain. So if a drug increases histamine, it'll reduce the sensitivity to histamine. This applies to mood stabilizers, antidepressants, benzodiazepines, antipsychotics, each with their particular receptor or neurotransmitter that's affected. But the brain is a plastic organ and it'll adapt to these drugs. Now, when you're taking the drug, normally there's an equilibrium formed. The brain will become more or less sensitive, and that'll match the levels that are supplied by the drug. And so things tend to stay in equilibrium most of the time. Now, when you stop the drug, things change. So when you stop the drug will be supplying less of whatever neurochemical it's supplying. The brain is used to more of it. The difference between what the brain expects and what the drug is supplying will cause withdrawal effects. And so the worst way to stop a psychiatric drug, the way that it's guaranteed to give you the most trouble, is to throw it in the bin, is to stop it abruptly. Your brain expects this much, and you have gone, the drug is supplying about that much, and you've gone now to zero. That difference is going to be very large.
Yeah.
I describe that sometimes like jumping off the top of a building. Your brain is used to 10 stories of the chemical that your drug is supplying. You've gone down to ground floor, and in jumping that far, you can do yourself considerable mischief.
That's a good way of explaining it. Mm-hmm.
So then the opposite of that, stopping abruptly, is going down step by step down all the stories. So it takes a lot longer, but you're walking down the stairs, and that is what tapering is. It means you're making smaller reductions than you were when you did it in one go, and that will cause some difference between what the brain expects and what you're supplying it. But the brain will get used to it each time, and if you do it slowly enough, then the difference between what the brain expects and what the drug is supplying will be small enough that it won't cause terrible trouble. I would say like banging your knees going downstairs versus what happens if you jump from the 10th story to the bottom.
Okay.
And so the main principle is if you reduce your drug gradually, you will spread out the withdrawal effects from all in one go to smaller amounts over time. And most people can find a rate of reduction that's tolerable for them, that fits into their lives, whatever they are. Some people can tolerate a bit quicker, some people can tolerate a bit slower, and most people can find some rate that they can tolerate in their lives. And what is probably happening in that process is whatever that initial change, a reduction in sensitivity to serotonin for antidepressants, is probably slowly reversing. You might say the brain's returning to its factory settings before the drug was put in. There's a lot of debate about will it ever get back exactly to factory settings, but it'll move towards that. In other words, the changes caused by being on the drug will slowly reverse. And if you do it slowly enough, it'll have time for the brain to get used to lower levels.
Mark, can I quickly ask a question here? So can you briefly, before you go into the detail, which is amazing, is just quickly explain that staying on the antidepressant or the benzodiazepine or the antipsychotic or even a stimulant like Adderall, Strattera or something, Ritalin, staying on it doesn't necessarily keep your brain, there's a homeostasis, but there is also another thing that happens, it's not a long-term, it doesn't mean that your brain stays healthy. These things do have long-term effects that are negative. So they should be more used in an acute sense than a chronic sense, a chronic use. Could you talk just a little bit about, because some people may be thinking, oh, well, then let me stay on to keep homeostasis. But I think we need to be informed as to if you stay on, yes, there's a level of homeostasis, but there's a bunch of other stuff going on that will impact. And you've already described your own experience, the sleep, the fogginess, which really worried you, and the clarity of thought and so on. You could talk to a little bit to that.
It's a very good point. So I guess when I'm talking about homeostasis, I'm comparing it to what happens when you stop. But exactly as you say, these drugs, from research that we have, tend to have adverse effects on the brain. So we don't know the exact mechanisms. We know, for example, for antipsychotics, there seems to be shrinkage on the brain that you can see on brain scans. I was actually recently shown a paper by my professor that shows that antidepressants can also cause more subtle reductions in size of the brain. There's been less research on other psychiatric drugs, but we know that altering the chemical balance of the brain can have negative effects. So that's very clear when we think about recreational drugs. So when we think about someone using ecstasy or amphetamines long-term, we implicitly understand that those sort of things are not good for the brain. And we see that in people's behavior. They become cognitively impaired, they have sleep disruption, they can often develop mood problems. It's a longer conversation, but we should be more aware that psychiatric drugs have strong similarities to recreational drugs. They affect similar receptors. We know that benzodiazepines essentially have almost identical properties to alcohol. They're probably a bit less toxic to the liver than alcohol is, but they affect GABA receptors. There are similarities between antidepressants and drugs like MDMA and ecstasy. They both affect the serotonin transporter. MDMA and ecstasy are probably stronger and have larger effects on serotonin, but there are similarities. Through that lens, if we sort of ignore, some of them come in packets with drug company lettering on the front, and some come in powder form in little packets from dealers. We just look at the pharmacology, which is what I'm interested in. There are great similarities between recreational drugs and psychiatric medications.
That's a very good point.
Yes. And a lot of the effects of recreational drugs we can see in patients who are on psychiatric drugs long term. So, for example, I highlighted a few that happened to me, but it's on the package insert of many of these drugs. If you open up a packet of an antidepressant or a benzodiazepine and pull out the leaflet that's written by the drug company and approved by the FDA or the equivalent in your country, it will list many of the symptoms that I mentioned that I had: daytime tiredness, trouble sleeping, insomnia, memory and concentration impairment, weight gain, disrupted dreams, all sorts of things. We know that these drugs affect every organ in the body. The reason why people have sexual side effects is probably because these drugs affect the hormonal system of the brain and the body. So we know that these drugs will affect every aspect of human biology in the long term. They are not targeted where they only act on certain receptors in the brain. No drug is that clever. They work on everything throughout the entire body. And that's why people can have such a wide variety of symptoms. I often get people in my clinic, because I run a clinic that helps people to stop their psychiatric drugs, simply to pull out that piece of paper from inside their drug packet and to tick off which symptoms they have. Because many people have been told, don't read it, it's written by the lawyers, not a big deal. It is written by the lawyers. It's written for a reason, because they've been sued for those symptoms.
Exactly.
So then they're not trumping it up. It's often an underestimate of the adverse effects.
Yeah.
Because taken from short-term studies, from 6-week, 12-week studies, people are on these drugs for decades. The cumulative effects can be worse. We know that there are studies that connect use of antidepressants and benzodiazepines long-term to risk of Alzheimer's. For benzodiazepines, there's a clear link to increased risk of fractures, falls. There's even suggestive evidence that increases risk of infections and cancer. So there are all sorts of risks to long-term treatment. And so that's certainly one of the reasons why people should be always evaluating what the balance of risks and harms are from being on these medications.
The informed consent.
Yes, exactly. So I think, there's a lot of time spent by doctors talking about the benefits, much less time talking about the harms. And I think that's exactly that needs to be rebalanced. And then before I go into talking about how to stop these drugs safely, another thing I hear from patients a lot is, I know I need these drugs because when I stop them, I feel worse. A lot of people will say that.
I've heard that comment many times. Mm-hmm.
Yeah. I thought I didn't need them anymore because I felt better, but then I stopped them. And that really gave me, a wake-up call that I need these drugs. And I think for a lot of people, they're mistaking withdrawal symptoms from stopping the drugs for a return of their condition. And that's probably worth just emphasizing for a minute because it's just so common. One, we know withdrawal symptoms tend to come on in a few days after stopping, that relapse tends to occur later on. But I also hear more and more from patients that even withdrawal symptoms can be delayed by weeks. We don't exactly understand why that is, but people have very distinctive withdrawal symptoms like electric shocks and trouble sleeping and anxiety that seems to be delayed for weeks after stopping. So I think we should have a high index of suspicion for withdrawal effects. Mm-hmm. The second way to distinguish after timing whether something is withdrawal effects or a return of an underlying condition is the symptoms. So I haven't talked a lot about them, but withdrawal symptoms from antidepressants, for example, can include all of the psychological symptoms in anxiety and depression: low mood, trouble sleeping, anxiety, panic attacks, obsessive thoughts. And in addition, they can also cause physical symptoms, things like dizziness, lightheadedness, headache, that feeling that I mentioned, derealization, that things are not real or they're dreamlike. It's a very common symptom I hear from my patients. Not being able to think straight. I've heard of very evocative descriptions like having cotton wool in your head, which sounds bizarre if you haven't had it. But to me, I know that intimately what that feels like. Just not being able to focus, feeling that things are very foggy is a very typical withdrawal symptom. Then there are quite distinctive sensory symptoms like electric shocks people have in their heads, a little feeling sometimes that their head is being switched off, or they get little zaps as they move their eyes. All of these sort of symptoms I've just mentioned, the physical symptoms, are not present in anxiety and depression, and therefore, mark withdrawal symptoms out as being from stopping the drug or reducing the drug and not from a return of their underlying condition. And along with that, if you went on a medication because you felt low and you had trouble sleeping, and now, years later, when you come off the drug, you have anxiety, you have panic attacks, completely different symptoms, psychological symptoms, yes, but different from what you had when you first went on, then it's much more likely that you're having withdrawal symptoms rather than coincidentally developed new onset of an anxiety disorder at just the moment when you've reduced your medication. In other words, we should have a high index of suspicion for withdrawal effects and not for a new onset of a mental health condition. And then the last thing that gives you a clue that the withdrawal effects are not a relapse is often starting the medication again, especially soon after you've stopped it, can clear up the symptoms in just a few days or a couple of weeks.
That's really key, isn't it?
Which can kind of, it's a bit retrospective because by that point you're already back on the drugs, but that can give you a little clue if they've cleared up fairly quickly that that's a sign that they were withdrawal symptoms and not relapse. So after saying that, I would say to many patients who think that being worse when they come off their medications, it's worth reconsidering. Did you have dizziness? Did you have headaches? Were the symptoms different? Did they go away very quickly after going back on the medication? Could it have been withdrawal symptoms? And very, very often when I see patients, that's what will come out. We'll go through those questions and I'll say, actually, I did have a headache. I did feel dizzy. It did happen 2 days after I went off the drugs. It did clear up within 3 days. And then we start to think probably it was withdrawal symptoms. And then the solution is not to be stuck on the drug forever, but to come off it more slowly, just as I've outlined, stepping down from that tall building rather than jumping.
So those are very key things, Mark, that there's very specific questions that you can ask yourself or someone you can ask, you can work through this with a medical professional who knows how to withdraw or who has some insight into this. But you're in the paper you talk about these as well, and then also in the Royal College of Psychiatry, that link there that they can have a look at. You do, it's clearly laid out, isn't it, that you've got what to look for which are most probably withdrawal symptoms versus a relapse. And the other thing that I wanted to ask you about this very quickly is a lot of people will say to me that they came off and suddenly the problem that they went on for in the first place, they realize they never addressed that. So then it is a sign that, okay, this didn't really fix anything. This just suppressed, added more problems to my life, and I haven't even addressed the initial issue, which that's something that I don't know if you find your patients saying quite a lot of that sort of thing to you as well.
Yes, absolutely. So it's a very good point when problems do come back. I think I see two categories of people. One, I see people who were put on medication when they were teenagers or in their early 20s. They had felt overwhelmed with life. Either they were, maybe a young parent, maybe their families were not as stable as they could have been. They just started working and they felt overwhelmed, as people in their teens and 20s do. And they started having panic attacks or they'd become depressed or anxious. And they experienced the medication as a relief when they went on it. I think that one of the main things that these drugs do is they dial down the volume of emotions. And I think numbing is a very common effect of all psychiatric drugs, particularly antidepressants, but lots of other ones as well. And that can be a relief for people who are in the middle of complete turmoil. But the numbing effects can, obviously are not targeted to negative emotions. They're targeted, they're not targeted, they're to all emotions. They're positive and they're negative. And so down the track, people come to see me because they feel numbed. They don't feel connected to their partner. They don't feel connected to life. The numbing is having a negative effect. And for some of those people who I see in their 30s and 40s and 50s or later, they have solved those issues that had first affected them. They are no longer overwhelmed teenagers or people in their 20s. They have stable families. Their jobs are stable. They're no longer, they developed some sort of coping technique. They found the right job fit, the right friend fit, the right partner. And so the issues are really historical, and they're just on the drugs often because when they stop them, they get withdrawal symptoms.
Okay, and then they've been told it's another label. Sorry, interrupted you there.
Exactly. So they, whatever label was first applied to them, they've outgrown it. Whatever generalized anxiety disorder, major depressive disorder, they sorted their lives out, and that's no longer relevant to them. They're functioning fairly well.
I know in the States what happens is in that situation, and I know it's happening in the UK and South Africa and Australia, is they then get multiple labels. You speak quite a bit about that, polypharmacy. So you think you're okay and you withdraw, and then you get another label, you get another drug, and you land up with multiple labels and multiple drugs, and it doesn't solve the problem. And actually, you you're on the side of healing, but we're always working at our stuff. I mean, there's never a day that there's always something new to work on, but you get to a point where you can actually deal with stuff. I talk a lot about mind management on this, which is a huge part of my work. And that's just, we're not going to have total peace, but we can learn we can't change our story, but we can learn how to change how it plays out into the future. And that kind of acceptance, and that kind of is almost stolen from you if you don't have a chance to go through that pain and process and find the source. And you're not even going to get the answers when you find the source, because you're not going to find out why someone hurt you or raped you or whatever. That's, those are answers you may never have, but there's a level of peace. Okay, I'm showing up like this because of, which the drugs are not going to do. They're not going to fix that.
Yes. So that's exactly the second group of people that I see, which is exactly what you said. The issues underlying emerge again, and the relationship troubles and the trauma history and all the things come out. And exactly as you've said, they've been numbed for many years. They haven't dealt with these issues. It's been locked in there. I've heard people say it's like an arrested development, because exactly all those things, all these aspects of human resilience, you experience trauma, it completely throws you off. You find ways of exactly reframing it. You find a more stable relationship or situation that allows you to rethink things, to develop different coping techniques. I think I'm very convinced that yes, drugs can interrupt that process, because for that process you need to feel your emotions and you need to think different thoughts. And if the medications are numbing the emotions and also making it a bit foggy in your thinking, both of those things are going to impair the ability for natural healing. I think some people can still do it on the drugs, but it is my impression that it does short circuit that process. It does stop that process from happening. I think probably more your area than mine, but I think a lot of what happens in therapy is people confronting very unpleasant emotions, shame, embarrassment, horror, despair, and getting used to them, reframing them. And if you don't have those emotions to start with, you can't approach them. So you've got
to deconstruct and reconstruct in order to be able to get some level of acceptance and move forward. And with the work that I've been doing, it was from early days in the 80s when I was training, when they told us that the brain couldn't change, to the mid 90s and I did some of the first work in my field in neuroplasticity. So I had an advantage in terms of the neuroscience, neuroplasticity, but from a mind, brain, body, holistic perspective. So that was how I ran my career and my practice and my research. But I was watching what you describing. I watched this happen. I watched patients come in. Fortunately, I found some doctors in South Africa that would help my patients, because I'm not a medical doctor, so I needed to work with a medical doctor to help them with withdrawal. But now we're at the stage now, and you commented, I've heard you say this a few times on interviews and things about, and you mentioned it in the beginning, that you've been challenged by, I think you said you were challenged by various doctors saying, hey, that's not a random controlled trial. But if you have hundreds and thousands, millions of patients globally telling very much the same story of descriptions of withdrawal symptoms and all these things we've been discussing, random controlled trials aren't going to, that's just going to, we need those. Obviously, I'm not saying, I do them myself, but we've got to listen to the evidence that's out there and apply that evidence, and not just say, oh, that doesn't count, it's anecdotal. You can't say a million people's same stories are anecdotal anymore.
I think it's a gross example of denial. I mean, of course, doctors are it's a little bit, of course, in evidence, a randomized controlled trial is more reliable than an anecdote. But in areas where there's not great trials, you go down to the next level of evidence. Doctors are very happy to do that in lots of aspects of what they practice. They say, work for me. So they're being it's a very defensive argument to say, well, in this case, hundreds of thousands of people, we ignore it. That's a completely ridiculous argument. We've got to wait for the trials to prove it's true. You don't need to prove that a parachute works. Once you have 500,000 people on websites saying they can't get off these drugs, anyone who's saying we need to wait for randomized controlled trials to prove it is in
denial. And how hard would it be to take all those cases, de-identify and do a statistical history? There's different ways of analyzing that kind of data, and you would have a full-on scientific study. That's something. Hey, Mark, why aren't you doing that? I'm going to say to you, there's a study that can be done that can show that this is valid data. Anyway, I'm diversifying here, but it is frustrating for the people that are on those sites and who've had experiences.
Yes, absolutely. I should say, and that argument is actually even more ridiculous, because actually there are randomized controlled trials showing withdrawal effects are very common.
Exactly.
Trials show that withdrawal effects occur in about half of people. There is survey and not randomized controlled trials, which show that the symptoms can be severe in a quarter of patients. So there is starting to be more and more evidence. People are picking up this topic. There are trials happening around the world on how to stop these drugs safely. A lot of it based on the work that we did. So it will start to happen. And I think the people that are now saying, "Oh, this is we don't have evidence for it," will start to look sillier and sillier.
Absolutely, especially in the light of the recent paper that you and Joanna Moncrief brought out, showing that the myth of the serotonin imbalance. And of 21 million papers, it's been the most cited, up in the late 300s in terms of being cited and quoted and the attention that it's drawn. It's just they want another solution.
Yes, I hope things are changing somewhat and people are more open to these ideas.
Can we make sure that we leave people, and I'm going to, just for the listeners to relax, because I know that they want to hear more. Mark will be coming back and we will be diving into these topics even deeper, and send us your questions so that we can be more specific. But for now, I would love us to talk maybe a little bit about, how do you do it? Do they cut up their pills? Do they do tapering strips? Do they do liquids? How do they do that? And if there's time, could we touch on esketamine? Because I know you've done work in that area, you've done research, and you have a strong opinion. And if we don't fit it in now, we'll bring you back for that. There we go. Let me give you the floor so that you can give us some practice.
How to come off psychiatric medications. I'll talk about antidepressants, but really what I'm saying applies to all different drugs. I've given you the broad outline, which is to come off the drugs slowly over generally months and sometimes longer than that. And I'll explain a bit about how I work that out with patients. Then the key is to go down in small amounts. And what does small amounts mean? So there's one thing to understand about these drugs, which is that very small doses of these drugs, and that's when I say these drugs, I mean antidepressants, benzodiazepines, all psychiatric drugs, have very large effects on the brain. So if I can try to draw a graph with my fingers, people have in their mind that if you have dose of the drug on the bottom and the effect on the brain on the y-axis, that there's like a straight line, that doubling the dose will double the effect. But actually, there's a hyperbola. Very small doses have very large effects and then it flattens out. So what that means is if you're on, say, 20 milligrams of a drug, about 1 milligram of that drug will have almost half the effect of 20 milligrams.
Wow.
So you go down by what I would call a linear amount, like a lot of guidelines suggest, going down from 20 to 15 to 10 to 5 to 0. It sounds like it's sensibly spread out, but actually in terms of effect on the brain, that first reduction will have a very small effect on the brain, then the next reduction will have a bigger effect, and that final reduction from 5 to 0 will have a huge effect on the brain because of that steep curve at the end. And that's what people's experience matches. I've had lots of patients say, I went from 20 to 10, it was fine, 10 to 5 was a little bit bumpier, but it was okay. When it went from 5 to 0 milligrams, the wheels came off, I was a screaming mess, and that very much matches the pharmacology of these drugs. And so what we published in 2019 in The Lancet was it makes more sense to reduce by even amounts of effect on the brain rather than even amounts of effect on dose. And what that means is you need to make smaller and smaller reductions as you get down to lower doses. So, for example, if 1 milligram has about half the effect of 20 milligrams, then you need to spend the same amount of time going from 20 milligrams to 1 milligram as going from 1 milligram to 0. So you sort of think 1 milligram is your halfway point. And so if it takes you 6 months to go from 20 to 1, then it should take 6 months to go from 1 to 0.
That's amazingly good advice.
So that's very counterintuitive. When people hear that, they think that doesn't make sense. But if you look at the chemistry of the way the drugs affect the brain, it does make sense. And what that, in shorthand, what that means is to reduce the drugs by a proportion of the dose. So, for example, halving the drug repeatedly, so going from 20 to 10 to 5 to 2.5 to 1.25 to 0.6 milligrams, that's sequential halvings, say 6 or 7 times, will actually give you approximately even reductions of effect on the brain. And the reason why you have to go down to such a tiny dose, so 0.6 milligrams, which is something like 1/50th of the starting dose, is so that final reduction in dose doesn't cause a bigger reduction in effect on the brain as those initial reductions. Not sure if that's clear. It's much easier.
No, that makes sense. It's that whole hyperbola.
It is. Next
time you can bring a graph.
So that means, one, you have to go down to these very low doses before stopping. So that final step down is not a huge jump, but just a small step. I gave an example of 50% dose reductions, but some people find that too quick. And so you can make divisions. So you go down by 25% of your most recent dose, or 10% of your most recent dose, or 5% of your most recent dose. And the phrase of your most recent dose is very important, because it means that as your dose gets lower and lower, that proportion will become smaller and smaller. So 10% of 20 milligrams is 2 milligrams when you start, but 10% of 1 milligram is only 0.1 milligrams. So as you get down to lower doses, you need to make smaller and smaller reductions. And so that's often explained to people as being proportionate reductions, which is a fancy term for meaning proportion of the most recent dose, so it gets smaller and smaller. And what was amazing to me was that what I derived, so everything I've just said, I took from brain scans of people on antidepressants that show this hyperbola. So I worked it out completely theoretically. What made me spit out my soup is that's exactly the advice people had worked out online through trial and error.
That's incredible.
So it was extraordinary. It's sort of like, when they realized that South America and Africa or whatever it is fit together, the continents, and they've been continental drift. These things fit together. What I had seen in the neurobiology fit exactly what patients were doing, and they had worked out. That's right, and they had worked out themselves to reduce by 10% of the most recent dose every month, exactly as the kind of the imaging of the brain suggests, and that's what makes me so convinced that it works.
Very quickly, I didn't want to talk much. Just quickly, how long should they take to do that? Would it be, or is it up to the individual? Is it a month or 6 months or whatever? Do they just judge it themselves?
That's the $64 million question. How long does it take people to do it? I've sort of developed a new kind of risk calculator. It depends on how long they've been on the drug for. The longer you're on it, the slower it needs to be. Depends on which drug. Some drugs cause much more withdrawal effects than other drugs. There are certain antidepressants that are worse than others, like duloxetine, venlafaxine, paroxetine. It matters. The best thing is what's happened in the past. If they've gone off their drugs and they've become completely destabilized, huge amounts of withdrawal symptoms, that's something that needs to go slowly. If they've noticed when they've missed a weekend on holiday, it hasn't caused them any trouble, that's something that can go a bit faster. So to put together all the different characteristics to have it. But what I do in practice is essentially do a test reduction, monitor withdrawal symptoms, and based on how severe they are, make the next choice.
Okay, that sounds good.
Make a 10% reduction, note your symptoms out of 10 for a couple of weeks. If the symptoms are completely fine, you go the same rate or quicker. If that was as much as you could tolerate, make the same reduction. If it was too much, go slower. And so for it's a very individualized, you're trying to balance two harms. You're trying to balance the harm of being on the drug too long unnecessarily and the harm of coming off too quickly. And so you're trying to navigate between staying on and coming off too quickly. And most people find a rate that they can tolerate.
That's very good. Okay. And that guideline is on the Royal College of Psychiatry, the sort of guideline, the papers, the attachment, a link. Okay, so now people are asking, in my mind, I know they're asking this, how do they do it? Is it liquid? Do they cut their tablets up?
Right. So, this is where things get complicated in practice. To start with, many people can just divide tablets. So when they're making reductions at high doses, there are some tablets that will allow you to reduce. It's very easy to halve a tablet or to quarter a round tablet with a tablet cutter. That's available for a pound or $1 at pharmacies or online. It's got a little blade. You just click it down and it cuts the tablet in half or a quarter. People get past that and they need to make more precise reductions. And at that point, there's 3 or 4 options. Sometimes there are liquids available for a drug. So in different countries, manufacturers will make a liquid of your drug, and you can use a small syringe or a dropper mechanism and measure out the volume that you need. Compounding pharmacies sometimes can make it up. They can be expensive, but sometimes they're not too expensive. You can order smaller dose tablets from a compounding pharmacy. There's one famous one in Holland that supplies something called tapering strips. Basically small doses, 1 milligram, 0.5 milligrams, 0.1 milligrams. Local pharmacies in different countries can sometimes do that. I think they're all over the place in America. Sometimes people who can't access any of those things are driven to quite to become kitchen pharmacologists, kind of Walter Whites of psychiatric drugs, where they open up capsules, they count out the beads inside, they count them out with a ruler on a black T-shirt and put them in other capsules in order to make small reductions.
Amazing.
People are sort of driven to quite extreme to make reductions. Some people will grind a tablet down with a nail file and use a jeweler's scale to measure the weight in order to make small reductions. That's amazing. Mm-hmm. Yeah, people are forced to be very inventive in order to make small reductions. It would be much better if people were able to be given access to liquid versions. They wouldn't need to become kitchen chemists. Other people will take, many of the tablets are soluble in water, and they will either put in water, stir it around to make a solution that they can use a syringe to make up different doses, or they'll grind up a tablet and dissolve it in water. So there are options. Every single drug will have some option that works for it. There's good guidance online. We're writing a textbook at the moment that'll explain all the different options for all these different drugs.
That's amazing.
Will be helpful. But yes, in general, one of the main things for people is currently available tablets, too large a dose in order to make those careful small reductions, and people need to find alternatives. Exactly.
Well, that's incredible. You've given so many incredible alternatives. Mark, we're down to 6 minutes. Is there enough time? Do you want to say more about this, or can you touch on esketamine? And the only reason I'm bringing it up now, even if we dive into it deeper, is because in response to yours and Joanna's paper, I've seen so many psychiatrists actually saying, well, esketamine's a safe option. And even before your paper, this was out there. And this is something people ask me about a lot, and I'd rather you give the answer than me.
So esketamine is being marketed as Spravato in America and countries around the world. And it's said to be a faster-acting drug that acts on a different system to serotonin. It acts on the glutamatergic system. And we analysed the data a couple of years ago, and what it shows is the following. This is the safety and the efficacy. So the studies, they did 3 short-term studies that went for 4 weeks. Very short-term. It's incredible they were allowed to do such short-term studies, because most people get the drug for months or years. 2 of the studies showed no difference between esketamine and a saltwater spray. So people were spraying salt water in their nose, and in 2 of those studies, there was no difference between esketamine and the saltwater spray at 4 weeks. One of the studies showed a very small difference, a 4-point difference on a depression scale, which I think is about 50 points. Most commentators think that difference is too small to really matter. But actually, there's other reasons why that difference could exist. People are given a drug that causes dissociation. Esketamine is a dissociative anesthetic. Mm-hmm. It makes them feel differently. They know they're on the drug. We know that when people know they're on a drug, it will give them expectation effects. They're going to get better. Placebo. And that can explain the difference, which is called the amplified placebo effect. Then we've got to step back and think about actually what is the drug doing? Is it curing depression? What it's probably doing is making people feel a bit different. We know that ketamine is a dissociative anesthetic. It's used in anesthetics. It's used as a recreational drug. You can see videos of people on YouTube wandering around, off their face on ketamine. So what is it doing? It's probably making people a bit euphoric, a bit high, a bit dissociated, which might distract them from their emotions for a little while. But like for other recreational drugs, we know that doesn't last. This is sort of like saying alcohol is good for anxiety. It probably is in the short term, but in the long term, a drug like alcohol that superimposes sedation or anxiolysis is not going to have that effect in the long term. We know that from seeing alcoholics. And the same thing is probably true for people on ketamine. People who use ketamine long term are not happy, relaxed, well people. Ketamine is neurotoxic. It has neurotoxic effects on the brain. It causes cognitive impairments. So it's likely not to keep these properties in the long term. So the effects were very minor. There were some quite worrying safety issues in the study. We know that there's a thing called ketamine bladder, where people's bladder starts to stick together when you use ketamine too much. The lining of the bladder becomes sticky, and sometimes it happens that people can no longer pass urine and they need to get a catheter in, and they get very painful sensations. In the study, terrible. Where they've used, and it's worth noting, they use doses that are a bit less than recreational doses, but not that much less. They're sort of down to the bottom of what people are using on the street. And there was lots of urinary problems in the study. There were bladder problems, and some of the researchers said this looks a little bit like ketamine bladder, but it was only 4 weeks of a study, so it's very unclear what's going to happen in the long term. So there's that issue. There was also a number of suicides in the study. And interestingly, all the suicides happened in the group given the esketamine and none in the placebo arm. And people have pointed out, well, there was more patients in the esketamine arm, and that's true, than in the placebo arm. But it is still a bit alarming that there were 3 suicides in the esketamine arm.
Yeah.
Because the inclusion criteria for the study were you cannot be suicidal and you can't have had any suicide attempts in recent history. In other words, these people were selected for not being that severely depressed or suicidal. And so to see that 3 out of more than 1,000 patients committed suicide, and only in that side, does raise alarm bells. Those alarm bells were added to by a study done in America since the drug has been released after a year, which found that reports to the FDA about esketamine had an unusually large number of suicides and suicide attempts. So there's 2 signals there. In the study, there was an alarming number of suicides. In actual practice, there seems to be more suicides happening than people would expect, even in this population of people who are depressed.
Yeah.
And try to make sense of it, I read a lot about what do these drugs do to people. If you go to drugs.com, people will write down what happens to them. And some people enjoy it. They say it was a great, interesting trip. They like the K-hole, which is what recreational users talk about. There's a whole other group of people that have alarming, bizarre experiences. There's a grown man who says he felt like he was on a Ferris wheel, started crying for his mother. We know these drugs are psychotomimetic. That is, esketamine and ketamine is used in studies to induce psychotic symptoms in people. And so it sounds like some of these people are becoming a bit loopy, a bit crazy from the drugs. And maybe that's what's causing them to be suicidal or to do things like that. That's one of the mechanisms proposed. There's a whole lot more to go into, but ketamine, we know, is an addictive drug. It causes dependence. It causes withdrawal. There's already stories coming out of clinics saying patients can't stop it. Withdrawal effects are too strong. People are asking for more and more of the drug. My biggest concern is that this may be a repeat of the opioid epidemic, with people started on drugs that are addicted by their doctors, supposedly in safe environments.
Yeah.
We need more and more of the drug and therefore move on to the street where you can easily buy ketamine.
Exactly.
It leads to all sorts of trouble. So I think, we are, Janssen, the company that makes this drug, is essentially taking a recreational drug that gets people high and is rebranding it as a medicine. And that's going to cause all the sorts of problems that always causes. I think that's what's going on with esketamine.
Wow. You have said it in unbelievably brilliant way, and I thank you. And I'm just glad you said all those things, because this has been my concern, and watching the research you've done and everything, this is what I'm seeing as well. And it's frightening. So we'll dive into it deeper, but you've given an incredibly good synopsis, and I didn't want to leave people hanging because people are asking about that. So I'm pleased for that. Brilliant interview. I look forward to bringing you back again and taking these topics deeper. So thank you, Mark, for your vulnerability, your honest, your openness, and being so driven to solve this problem, and coming from the very highly educated position that you are. Your impact is going to be huge. So thank you for your help. Really fantastic that people that reach out to me now can say, go listen to this podcast, get those links. So we'll make sure we get the proper links up, and thank you for your time.
Okay, thanks very much. Thanks, Carol.